Good morning, everyone. Good evening, good afternoon. We'll just wait a couple of minutes for everyone to join us. Good morning, good afternoon, good evening to everyone. We welcome you, particularly those of you who are joining from far away or at late or early times. Welcome and thank you for joining today's WHO EPI-WIN webinar on women in health emergencies. For those of you new to EPI-WIN, this is the WHO Health Emergencies Information Network for Epidemics. Our goal is to translate knowledge and science in accessible, understandable, and relevant ways for evidence-informed actions and decisions in health emergencies. Our webinar today is following International Women's Day, talks about a very important topic because women are disproportionately affected by health emergencies, but their voices are not heard. We have a very exciting panel of women leaders to both celebrate the role of women in emergencies, but also bring light to how we can bring more women to the decision-making table. As you can see from the agenda on the screen, Dr. Niluka Vijayakun, Technical Officer and focal point of the WHO Health Emergencies Gender Working Group, will set the scene and she will moderate the technical discussion. Then we have the opening remarks talking about the disproportionate burden of women in crises by Dr. Stella Chungong, who's the chair of the Gender Working Group and also director of Health Emergency Preparedness at WHO. From the regional perspective, from the Southeast Asia region, we have Dr. Sugandhika Pereira talking about the critical role of women's leadership in emergencies. Then Dr. Mary Stephen, WHO representative for Eritrea, will talk about the country level and women's contribution to health emergencies. Then we have a partner perspective from the CSO perspective. We have Dr. Serena Leung, founder of Be Priceless, who will talk about the voices of vulnerable populations in crisis settings. And finally, to bring it together and talk about what we can do, how we can advance gender equality and women's empowerment. We have with us Dr. Alia El Yassir, who's the director for Gender Rights, Equity, and Sexual Misconduct Prevention at WHO. Before I go further, some housekeeping. This webinar is being recorded and the recording will be shared on our website along with the presentations of all the speakers with their permission. We invite you all, many of you are part of the EPI-WIN family by now, to introduce yourself, put your name, location, organization in the chat box, and if you have any perspectives to share, please do share it in the chat box. We love to hear from you. But if you have questions, please put it in the Q&A box, not in the chat, so that we can keep track of them more easily. But finally, while we love to hear from you, please keep your comments constructive and positive. This is a positive forum to help us all for knowledge sharing. Any disrespectful comments will be removed. Before I hand over to Niluka, I would now like to hear from all of you. As you all know, this is an EPI-WIN tradition. Please go to slido.com, hashtag 2063361. And okay, the first question is, we have two questions here, and we'd love to hear from you, is in 2024, what percentage of global aid did women's organizations in conflict zones receive? Is it 25%, 12.5%? 8% or 0.4%? Very quickly because of time constraints, but I hope, I see we have more than 500 people right now online. So please, more of you, I'd like to see more of you joining here and giving your. So we have 46 people answering this. Please, some more would be great. Okay, this will be open, and maybe I will share the answer with you at the end of the webinar. But in the interest of time, I will go on to the next question, which is, according to the 2025 UN Secretary General's report on women, peace and security, how many women now live within 50 kilometers of a deadly conflict? And I think in 2026, the numbers may have changed. Okay, from here, the majority of you think 36% so far, others 32%, that's fairly close, about 23% think 6 million, and 7% think 10 million. We have 94. Okay, so I will share the answer with you for the previous one. You were wrong. Those of you who said 48%, although that's the majority, it's actually 0.4%. So you can see there's a long way to go. And the next one, it's actually, well, this was 2 years ago, 676 million. So that's how much women are affected by emergencies. I'll stop here and hand over for the technical session to Niluka. Over to you, Niluka.
Thank you very much, Supriya. Welcome, everyone, and thank you for joining us as we celebrate and commemorate the International Women's Day with this important webinar on women in health emergencies. I'm Dr. Niluka Vijay-Koon, Technical Officer, Epidemiologist at the Department of Health Emergency Preparedness, as well as the focal person for the Gender Working Group of WHO Emergencies Program at headquarters in Geneva here. Around the world, we know women are often on the front line of crises as responders, as caregivers, community leaders, and sometimes as survivors. Yet their contributions and challenges too often are overlooked. Highlighting this topic matters, and as we elevate women's role in emergencies, we strengthen health systems, we strengthen community resilience, and we create more equitable responses. Today, we are fortunate to have an exceptional lineup of women experts who bring deep experience, insights, and leadership to this conversation. Together, we'll explore not only the realities women face in emergencies, but also concrete ways how we can drive meaningful change. And thank you for all of you. We have around 650 colleagues joining, being part of this dialogue, and for helping to create a safe and more inclusive future. So without further ado, I'm inviting Dr. Stella Chungu, who will deliver the opening remarks specifically on women in emergencies, highlighting the disproportionate burden the women experience. Dr. Stella Chungung is a global leader committed to advancing global health security and championed in multiple public health initiatives. She's currently the director of the Health Emergencies Preparedness Department at the WHO headquarters in Geneva, and she's also the chair of the Gender Working Group of the WHO Emergencies Program. Dr. Stella, I kindly invite you to start the webinar.
Thank you so much, Chair. Good morning, good afternoon, good evening to you colleagues and partners joining us from around the world. Today's topic is one that is close to my heart, and it is both urgent and essential: the role and experiences of women and girls in health emergencies. When emergencies strike, whether outbreaks, conflicts, or climate-related disasters, they affect entire communities, but they do not affect everyone in the same way. Time and again, evidence shows that women and girls face greater risks, deeper impacts, and heavier responsibilities during crisis. These inequalities do not begin with the emergencies themselves. They are rooted in pre-existing structural gender disparities. These can be social, economic, and cultural inequalities that already shape women's lives. When a crisis hits, those inequalities become amplified. Structural differences in access to information, resources, mobility, and decision-making shape how people experience crisis. And these differences often place girls and women at a disadvantage. Take something as basic as access to information. Early warning messages and risk communications are essential during an emergency, but in many settings, women may have lower literacy rates, less access to mobile phones or digital platforms, or fewer opportunities to participate in community decision-making spaces where information usually circulates. As a result, critical information about risks or protective measures may not reach everyone equally. Mobility can also be a challenge. During disasters or conflicts, evacuation or access to safe shelters may be difficult for women. Caregiving responsibilities often fall disproportionately on them, caring for children, for the elderly, or even family members who are sick or injured. These same barriers are often affecting access to healthcare. When emergencies disrupt a health system, the obstacles women already face in seeking care can grow even larger. This is especially true when stigma is associated with the health condition involved, whether related to sexual or reproductive health, sexually transmitted infections, gender-based violence, or mental health. Another reality we must acknowledge is that emergencies often increase the risk of violence against women and girls. Globally, 1 out of 3 women experience physical or sexual violence during their lifetime, most often by an intimate partner. During crisis, these risks can intensify. During the COVID-19 pandemic, for example, studies estimated that the prevalence of intimate partner violence reached 31%. This reflects what many describe as a shadow pandemic that unfolds besides an existing crisis. In humanitarian settings and conflict zones, the situation can be even more severe. Amongst refugees and internally displaced women, researchers suggest that 1 in every 5 women, that is approximately 21%, report experiencing sexual violence during displacements. Despite facing these risks, women are also at the center of how communities cope with emergencies. Caregiving roles do not disappear during crisis. If anything, they become even more demanding. Women are often the primary caregivers within families and communities. During disease outbreaks, they are frequently the primary carers within households. In displacement settings, refugee camps, or temporary shelters, women continue to sustain families and support others, even in extremely difficult conditions. At the same time, women are also at the front line of the response itself. Globally, women represent about 70% of the health and social care workforce. This means that they carry a significant share of the exposures and the operational burdens during outbreaks and health crises. All of this points to a simple but important conclusion. Gender equality is not only a social objective, it is a fundamental right that needs to be implemented for effective emergency preparedness and response. If we fail to consider gender dynamics or responses, our actions will inevitably miss critical risks and overlook important capacities within communities. There has been real progress in recent years. Across the global health and humanitarian communities, we are integrating gender considerations into preparedness planning, response operations, and recovery efforts. Each crisis teaches us important lessons, and we are slowly building stronger frameworks to ensure that women and girls are better protected and better empowered. But the work is far from finished. Building truly resilient health systems and communities require us to continue strengthening women's participation, to continue addressing the barriers they face, and to continue ensuring that emergency preparedness and response reflects the realities of women's lives. Because ultimately, creating safer and healthier societies mean ensuring that women and girls are not only protected during emergencies, but empowered to shape the responses that affect their communities. We have an impressive panel today who will deep dive into these issues, and I look forward to the discussions and exchanges. Thank you, Chair.
Thank you very much, Dr. Stella, for setting the stage so powerfully. And now we move to Dr. Sugandhika Pereira, who will speak on the critical role of the women's leadership in emergencies, especially sharing the regional perspectives from the Southeast Asia region. Dr. Sugandhika Pereira is the Program Area Manager, Emergency Operations, WHO CRO, that is Southeast Asia Regional Office. In fact, she's the first woman to hold this position in CRO. She's a medical doctor with over 20 years of public health experience across national and international settings. She was previously the National Program Manager for Disaster Preparedness and Response at the Ministry of Health, Sri Lanka. Dr. Sugandhika, the floor is yours.
Thank you so much, Chair. Good morning, good afternoon, good evening, colleagues and friends. Yes, okay. So it's a pleasure to be here with you today and share some thoughts from a regional point of view. Next slide, please. So this is the WHO Southeast Asia region, the region that I work in. It has 10 countries. You can see almost a quarter of the world's population, and a region vulnerable to every hazard in the textbook, be it natural disasters like floods, landslides, outbreaks, Nipah, you may have followed recently, cholera, dengue, and very much affected by climate change, rising sea levels, extreme weather events, which is almost becoming the norm nowadays. We are also home to the largest refugee camp in the world, one of the largest refugee camps in Cox's Bazar, Bangladesh, where we have over 1.3 million refugee and host population. So all in all, Southeast Asia, we are responding on a daily basis to some emergency. Next slide, please. What about the female workforce in emergency response? I do agree with Dr. Stella when she says that it's not about the female workforce in terms of numbers. My experience is it's not that we don't have women in workforce, but it's the distribution at which level. Women are very much at the front line, that is in the hospitals, in the field, and in the operational context for health interventions. You have two photographs here, which you can see the frontline workers. On the left side is the most recent emergency we had in Sri Lanka, cyclone and landslide, following Cyclone Ditwa, the floods and landslides. And you can see the difficult terrain in which these midwives and the community health workforce is working in, the risks. On the right side, you see a temporary hospital in a refugee camp, and you will see it's mostly females who are there looking after the patients. So it's not that we don't have numbers in emergency operations, but it's basically what the level is. If you look at the top level, if you look at a picture from a steering committee or a high-level committee, which I have not included here, you will see that it's almost the opposite. Women are often underrepresented at the highest level. The perception in our region is that women work under high-pressure conditions? Are women weak? Can they be effective leaders in emergency operations? But if we talk about it, it would seem like we are challenging the patriarchal decision-making structures that we have been seeing in our region for decades, if not centuries. Next slide, please. So let me bring in a few thoughts about why women in leadership is critical in emergency management. One, more inclusive and needs-based decision-making. I think we heard from the previous speakers that women are disproportionately affected whatever the disaster is. So women in leadership can ensure better recognition of this and prioritization and prevent any blind spots. In many of our countries, women have lower mobility during disasters, greater caregiving responsibilities, less control over resources, and with limited decision-making power on top of the different needs, which was very much highlighted by Dr. Stella as well. So women in leadership help to ensure that we, in response, in our public health interventions, when we are planning, we account for all these. Reproductive health, violence, harassment, safety in shelters, menstrual hygiene, female-headed households in emergencies. So it's important that we take into account all these factors. Next slide. Keep it. Point number 2. Okay. So stronger community trust and participation. As highlighted earlier as well, women are often central to community networks, and it's a huge asset in emergencies. Women frequently lead and comprise majority of the community health workforce and health volunteer networks. You saw even in the 2 pictures and even in some of the pictures that were there from the fly itself, how women are there at the forefront of emergency operations. So basically, there is more trust and participation when women are involved. So women in leadership can leverage this social capital better. Improve protection and safeguarding. We all know of gender-based violence during disasters, trafficking, harassment risks in camps and shelters. And what about the protection and safeguarding of our female colleagues who are responding in the field? So women leaders are often more proactive about gender-based violence and harassment mitigation and respond to violation of protection promptly. We don't put things under the carpet. We see that. So basically, all this will improve not only the safety, but also the credibility and the accountability of our public health interventions and response. Better team performance and decision quality. There are many publications across sectors, including humanitarian work, consistently showing that women leaders tend to adopt collaborative, inclusive, and communication-rich leadership styles. And this is very contrary to the picture that is often portrayed when we are talking about female leadership. In emergency response, the qualities I mentioned, collaboration, inclusion, communication, is very much translated into better information flow, higher team performance, faster conflict resolution, and a more supportive working environment. It is this cohesion or the binding that directly improves the operational performance and in high-pressure situations. Look at our smallest unit in our communities, the households. Who is the binding factor, the glue in the household? It's the grandmother, it's the mother, the wife, sister, daughter, who is the binding factor, the glue. And it is this glue that we bring in even to our teams and in emergency operations and response. Last but not least, a more sustainable and a long-term recovery. Basically, women bring onto the table a more holistic understanding of the health needs. No blind spots, better communication, coordination. And these are all important for sustainable and long-term recovery. So these are just some thoughts that I shared with you based on my experience, and that is the end of my presentation, and would be happy to take any questions. Thank you.
Thank you very much, Dr. Sugandhika, for the great insights. We do have a question. So you've seen over the years being the first operations program area manager. How do you see the leadership roles being taken up? Do you see more and more women taking leadership or decision-making roles in the Southeast Asia region with every new emergency that comes?
Thank you very much, Chair, for that question. I go back almost 17 years when I started emergency response, and I still remember when I went home and told my parents that I would like to join emergency operations, and I cannot forget the look on my father's face to see what is she talking about, kind of an expression. But I do see a difference and a very positive trend moving forward. Of course, it's baby steps. We do have a long way to go. And through sessions like this, more awareness, more females are opting for emergency response related work. And that is a very positive trend that I see. We do have a long way to go, but I would definitely say that we have come a long way as well. Thank you. Back to you, Chair.
Thank you very much. Now we move to our next presenter, and that is Dr. Mary Stephen, who will talk about the women's contribution at the country level. Dr. Mary Stephen is the WHO representative of Eritrea, and she's a public health expert with over 20 years of experience working across WHO across countries in the Africa and the Eastern Mediterranean. Previously, she was also the acting WHO representative for Lesotho, and she's a passionate mentor for women in health. Dr. Mary Stephen, the floor is yours.
Thank you very much, Dr. Niluka. Happy International Women's Day to all the women on the call, and a big thanks to the men that are supporting us. So I will be talking about country experience and women's participation at the country level when it comes to emergencies. Next slide, please. Okay, so as we heard from Dr. Stella about the importance of emergency preparedness globally, but I would also like to add that countries are at the center of this emergency preparedness and response effort, because as we all know, outbreaks begin and they end in communities. And these communities are situated in given countries. And therefore, it is very, very important to make sure that we are strengthening effort at the country level to enhance capacities for emergency preparedness and response, to facilitate our ability for early detection and mounting an effective response. And we also need an effective health system strengthening, actually, because emergencies and health systems, they go together. And we also had the statistics from Dr. Stella. Women play a critical role when it comes to emergency preparedness and response across all levels. But this role is even more critical at the country level. We had the statistics, 70% of the health and social workforce are actually women. And most of these women are situated in countries. And therefore, their participation is very crucial to make sure that we are responding and recovering well from health emergencies. Next slide. Okay, so what are the ways that women contribute to health emergency preparedness and response at country level? The first is on leadership and policy. In our country where I serve right now, Minister of Health is a woman. Myself, the WHO representative, a woman. But we have also seen women at different cadres of leadership, not just here in Eritrea, but across the world, in the ministries of health, other relevant ministries. We talked about from our previous speakers, it's not about the availability actually of women to serve. But what is the percentage in terms of decision making? What is the percentage contribution of women? We saw from the COVID-19 pandemic response the great work that women did as heads of government, the former Prime Minister of New Zealand, the former Chancellor of Germany, the head of government in Taiwan, the excellent work they did in terms of strong leadership, which actually made their response much more effective than so many countries that are led by men. We also have women as responders. We said they are more than 70% of the workforce. At country level, you find them everywhere in our hospitals, in our ministries of health. They are there at the front line, contributing to emergency response. But also, women are contributing to all the different capacity building efforts we said we need to prepare for before we respond. And until we are prepared, we are not able to respond effectively. So all those capacity building efforts, women are contributing in terms of participation, but also facilitating. Then we heard from Dr. Stella, caregiving. Traditionally, is considered the role of women in a patriarchal society. And in emergencies, women, in addition to all the different roles they play, they take additional role to be caregivers during emergencies. The issue of community, most women are the ones that are mobilizing the communities during emergencies. They influence decision-making at the community level. They help to facilitate community trust. Then, most importantly, they nurture the next generation. So women are there either as mothers or guardians because we live life. And so that's God-given capacity of women to nurture. We have these girls in our homes, and women continue to contribute, whether we know it or not, in one way or the other. Our mothers, our grandmothers, our sisters, our aunts have contributed to nurturing us women as leaders today. Next slide. Okay, so despite all this, women face a lot of challenges when it comes to their participation in health emergencies. The first been spoken to by the two speakers that spoke before me on the representation of women in leadership roles. So it's not that we don't have the numbers. We have the numbers, but when it comes to leadership decision, the women are actually left behind. So you find more men on the leadership and decision-making roles than women at the country level. And this has an impact, of course, of the women decision-making roles, even at regional and global level. And the risks that women face much more than men when we respond to health emergencies. First, frontline health workers. We saw women that were affected during so many emergencies, whether it is COVID, Ebola, Marburg, different kinds of humanitarian crises. Women are at the forefront of this response, and they carry this additional burden, actually, even as caregivers, as health workers. Then we have this challenge of also having the woman in the workplace, and then you have to balance the cultural and societal norms and still thrive in your career as a woman, especially in health emergencies. I heard from Dr. Pereira earlier. She was talking about the issue of women, whether they are able to participate in health emergency work. It's considered, I think, unconsciously a man's job because it's a little bit stressful, of course, and women being viewed as not that agile when it comes to physical strength, then that subconscious bias is there. and then balancing the responsibility of the woman in a patriarchal society, being the mother, a sister, aunt, and also where the society has placed her in terms of the norms, the culture, and the biases that we have, and sometimes we don't even know they exist. At policy level, we still face challenges of adequate policies that allows women to participate effectively, especially in health emergencies at the country level. But we also have gender inequality when it comes to career advancement. Women have to put like double the effort a man will put for them to even be seen out there in the workplace. And so these are some of the challenges that we face. Sometimes women don't even have, they are not given the opportunity, basically. Like they are not trusted to take those positions, especially when it comes to the leadership roles in health emergencies. Next slide. Okay, so then how can we improve the participation of these women? I call it it's a call to action. Everyone has a role. We all have a role to play in contributing to improving women's participation in health emergencies at the country level. Whether you are a parent, whether you work with the government, you work with WHO, the UN, whether you are a teacher, whether you are a community member, you work with the NGO, whatever role you find yourself in, you have a role you have a role to play and contribute to making sure that women participate effectively in emergencies response. We need to catch them young. So as parents, we have a responsibility because we have seen all these challenges that women are facing in the world, in the countries, in the communities. So we need to be intentional about educating our girls, our sisters, our grandchildren, our nieces. We have to be intentional about preparing them. She needs to hear that voice that helps her to believe in herself, that helps her to think that she can still compete effectively in a world that is highly men-dominated and societies that are highly patriarchal. She needs to hear that, and especially if you are a man, I would like to throw this challenge to you. She needs to hear it from you as a father, that she can do it, and you are solidly behind her. You will help her grow to it. Because that little girl you see in your house is the emergency leader for tomorrow. And therefore, you have that responsibility right from that childhood to make sure that you are investing in her career. Addressing the issue of societal and cultural norms, giving the women the chance as well to participate in this emergency response, but also in advancing their capacities.
Dr. Mary, so we probably have to go to the next speaker. I'm sorry to interrupt you, so we will give you a half a minute to finish.
Okay, so we talk about the issue of mentorship as well. We need to mentor our girls and provide opportunities for gender equalities. Can I have my last slide, because I have the final call to action? So we need champions, whether you are a man or a woman. We need you to be champions in your workplace, in your houses, everywhere in the communities, to promote your girls and the women and ensure that they are participating meaningfully in emergency response. Thank you.
Thank you very much for your contributions, insights, and sharing thoughts, experiences from the country level. So I think with time, I would now move to Dr. Serena Leung. And Dr. Serena will focus on the needs of the vulnerable populations in crisis settings. And Dr. Serena Leung is a critical care medicine specialist who has devoted 25 years for the advancement of the health and resilience of vulnerable populations in times of crisis. She's a trained frontline health worker across high-risk settings, and also the founder of Be Priceless, a Hong Kong-based non-profit organization that strengthens vulnerable children's protection. Dr. Serena, the floor is yours.
Thank you, Dr. Niluka. Dear respected WHO host, co-panelists, and friends attending today, I'd like to first invite all of you to join me in honoring the girls, the women, and the frontline workers in health emergencies, because you are in our hearts. Today, I have the privilege of sharing some 3 lessons I've learned from those I've served and from those I've served with in addressing the needs of vulnerable populations in crisis settings. I'm hoping that I'll be able to show you how we can integrate disaster risk management with health education with protection. So my first lesson is that we must provide integrative care at every contact. So sometimes I work in refugee camps to train community healthcare workers, and many of them are young women. They're both the carers of the community or the healers of the community. They're also the survivors of conflict, outbreaks, as well as displacement. So what they really need is both for themselves as well as for their patients to heal, as well as avoid secondary risks from further health emergencies. So while I'm supposed to be teaching medicine there, we often start with restorative practices for the health workers themselves, because many of us frontline workers did not ever learn to take care of our minds and bodies. So we learned before we go treat other patients, we learn how to take care of our nervous system, how to relax it. And then we also develop integrative patient care. For example, when we treat a patient with infection, we can also see if we can take care of maternal child care, whether that patient or the family members or extended family members, whether we can also ask about the situation at home. Are there any safety issues that we can help with? We can also do health education in terms of health emergency preparedness. And then we also explore the topics that's really close to the hearts of the health workers. So these young women told me gender-based violence is something at the top of that list. But oftentimes they feel really isolated, even though they're surrounded by colleagues. So we first learned to build restorative community amongst the colleagues, that co-learning. We also learned to extend that collaboration, that ability to hold compassionate dialogues, but also to hold boundaries and facilitate co-creation with the broader community of stakeholders in order to build shared solutions for stopping gender-based violence, as well as to protect survivors. So the lesson 2 I'd like to share with you is that we can build preparedness in everyday practices. I know that I hear a lot that vulnerable populations, when they're dealing with emergencies, they don't really want to deal with preparedness. In my experience, that's not really true. I think it has to do with when and how it's approached. So now I'd like to share with you the experience of Be Priceless. So this is a nonprofit that I started 10 years ago in Hong Kong to enhance vulnerable children's protection, well-being, personal growth, as well as their supportive relationships. So the majority of the girls and the women that we serve are from very marginalized communities. And the way we build our health education program is to enhance both health, meaning mental, physical, and social health, as well as build safety through teaching them disaster risk management that will extend to protection against violence. And let me give you an example. Who do mothers care most about? Their children. And what they care most about is their children's well-being and their safety. So we apply the WHO's Health Emergency Disaster Risk Management model to address the hazards that are closest to their hearts, like mental health crisis, violence, and then we move towards other risks like child marriages, outbreaks, extreme weather events. And so we engage both the girls and the mothers. So you see here an example of this little girl on the left. She's actually doing risk assessments. So with this risk seesaw, she's able to assess how her behaviors or the behaviors of those around her changes her risk profile. In doing so, she can make risk-informed decisions. So by the way, this risk seesaw is on the website, so free to use. And then girls and their mothers also collaborate to build preparedness plans. So in this middle part, you see a safety plan they build at home. And then on the right, you see the children, they are rehearsing, identifying early warning signs, early response actions, and seeking help. So through these actions, we're able to build preparedness into everyday practices. And then the last lesson is about the fact that the girls need to be safe to be healthy. We all know this. So the way we approach it is we train not only the girls and their mothers, but the boys and the fathers and the grandparents and the educators and the health workers, social workers, and the leaders of all these organizations, so that we have shared practices in building emergency preparedness, protection, and health. We also train the adults to be trusted adults, so they need to know how to identify risks as well as respond to risks when the girls and women face them. What we see is that 90% of the children and their mothers are able to use a preparedness plan even 6 months after our training, and that 60% of the girls and their mothers also have sustained improvements in health-related quality of life, well-being, and safety. So thank you for listening. We have many more resources related to the topics I spoke of in the links here. I hope you enjoy them and use them well to empower the girls and women in your community. Thank you.
Thank you very much, Dr. Serena. That was really quite a lot of work, very important work, and especially for the next generation. Now I have the pleasure to invite Dr. Alia Eliasser. Dr. Alia is the director of the WHO's Department of Gender Rights, Equity, and Sexual Misconduct Prevention. She joined WHO after nearly 3 decades with UN Women, where she has served in multiple senior leadership roles, including the regional director for Asia and Pacific and for the Europe and Central Asia. And I would like to start the session before I let her present, posing a question that is quite relevant in this context. We often hear about the phrase gender pushback, and we feel it, our programs feel it. And what roles the institutions, the programs, and the communities can play in effectively addressing and overcoming these in this context, and emergencies and overall health, public health. I give the floor to you, Dr. Alia. The floor is yours.
Thank you so much. And thank you also for the invitation to join. I think this is really a very timely discussion. We're meeting today to commemorate International Women's Day, but it's also to recognize a moment of really profound global upheaval. And in this very moment here in Geneva, there is also a whole conversation going on around the humanitarian reset. So it serves as an important reminder, and I think as we've heard from the interventions so far, that crises are not gender neutral, and so our responses can't be either. If we now look at why it matters for us to look at gender equality in and through health, and what does this, so that we can contextualize what we mean by the backlash or the pushback on gender equality. So you already have heard really powerful insights from the fellow panelists on what it means to protect and advance women's health in emergency contexts, and also the critical role that women play in public health overall. Let me step back a little bit and remind us all of the overarching goal. So gender equality in health means that all people, regardless of gender norms, have the equal conditions, opportunities, and power to realize their full right to health. This principle is actually already embedded in the WHO Constitution. It's also in a World Health Assembly Resolution 6025. It's captured in our new General Program of Work, as well as in the international normative frameworks that have guided them and that we as a UN entity adhere to. But we know that persistent gaps still remain, whether we're talking about access to sexual reproductive health, mental health, whether we're talking about older women's needs, even when we talk about communicable diseases or non-communicable diseases, and in areas that are gaining greater attention related to artificial intelligence and also climate change. When we talk about gender, we often fail to unpack it and understand what it means and how it affects health. Biological sex matters because we are speaking about physiology, genetics, and hormones, but it is absolutely critical for us to understand how gender norms and related power dynamics are profoundly shaping the exposure to risk, access and use of services, health-seeking behaviors, the treatment pathways, experiences that people have in the health system, and as we have heard from all of the speakers, whether women are influencing health-related decision-making, whether it is in households, communities, or in health systems themselves. And in emergencies, these inequalities become even sharper. We've heard women face greater violence. They have heavier caregiving burdens. They have also reduced mobility in many cases, and definitely less voice in the decisions that can affect their very survival. So today's work is particularly complex because of this pushback or this backlash. And just very important to stress that it is not just a random backlash. It is organized and it is transnational, and it is against these very issues that we're talking about. Anti-gender movements are framing gender as an ideology. They reject distinctions between sex and gender, and they oppose all gender-related language in international agreements, and that includes at the World Health Assembly. This backlash is not abstract. It is working concertedly to restrict bodily autonomy and rights. It is working to shrink civic space. It is weakening legal protections. It is rolling back the commitments that have been made on women's health. There is a whole slew of misinformation and disinformation that is associated with it, and it is eroding the multilateral mechanisms that we rely on in emergencies. And at the same time, women-led organizations, especially those in humanitarian contexts, are experiencing a crisis of trust and reduced resources. I heard recently, earlier this week, at another International Women's Day event from women-led organizations themselves. And they're telling us that already limited funds now are being channeled to larger non-governmental organizations, but we're leaving behind those small community-based organizations that continue to serve at the front lines. And we're leaving them under-resourced, overstressed, and excluded from decision-making. And this imbalance is also making itself visible as part of the humanitarian reset. And their representation is also diminishing before our very eyes. So in this critical moment, these organizations are asking for different approaches from all of us. They're asking us to work in a co-creative way, for us to share risks, and for us to continue to invest and deal with them with trust rather than suspicion. For WHO's work in emergencies, including the critical area of preventing and responding to sexual misconduct, as well as addressing gender-based violence, partnerships with local women's organizations are absolutely indispensable. And so we really have to keep this top of mind in our conversation. The evidence is clear. When women participate and lead, emergency response becomes more trusted, more locally grounded, and more effective. And when they are excluded, systems respond more slowly, then blind spots can widen and inequities deepen. EPI-WIN really plays a crucial role by bridging scientific knowledge with real-time decision-making, and it helps to ensure that the impacts that are based on these gender differentials are made more visible, and that emergency responses remain rooted in evidence rather than misinformation and disinformation. And so what I would say to you is that this moment really calls for courage from all of us. And I would like to highlight 5 concrete areas of action for our collective work. First, we really must continue to strengthen leadership and institutionalization efforts. We need strong institutions that are defending rights. Gender mainstreaming cannot be a minimum compliance exercise, and we need to ensure leadership support as well as dedicated expertise and targeted initiatives that are resourced. Second, we must continue to invest in evidence. High quality sex disaggregated data and analysis and looking at gender norms and power dynamics are critical for making inequities more visible and for countering these politically motivated movements that are aiming at misinformation and disinformation. Third, we have to continue to build gender responsive, rights-based health system. You've heard other panelists speak about this. We need systems that are safeguarding care, that address harmful gender norms, that address power imbalances and discrimination across policies, planning, financing, infrastructure, and service delivery. Fourth, we have to protect civic space and women-led organizations. These groups are the backbone of local response, and we have to continue to rely on them, but support them. We must recognize they are underfunded and sometimes excluded. And so we need to co-create programs with them, share risk, and invest in their capacities. And finally, we must confront the pushback with coherence and this collective courage. The backlash is well funded and it is well coordinated. So our response needs to be equally coordinated and resourced. This means that we have to continue to work with others, whether within this ecosystem, but also with the broader community-based civil society organizations, with member states, humanitarian actors, academia, and UN partners. So let me close by saying this. Achieving gender equality in emergencies is not only a moral imperative, it really is a public health necessity. If we want resilient systems, if we want trusted response and meaningful progress towards health for all, then women's rights, leadership, and safety must be at the center of everything that we do. The Director General has reaffirmed WHO's commitment to the UN system-wide Gender Equality Acceleration Plan, and this must guide our action across preparedness, response, and recovery. Thank you so much. And back to you.
Thank you very much, Dr. Alia, and thank you for an engaging and enlightening session. And so we basically come to the end of the presentations. But we also said that we want to continue the dialogue with participants, and we would take 1 question or maybe 2 maximum from the Q&A. I know that there have been some questions already looked at and answered. I would like to perhaps pose the question to Dr. Sugandhika. A question in the
just a minute, yes. Could you ask Dr. Alia to stop sharing screen?
Oh, Dr. Alia, can you please stop? Okay, thank you very much. So we have a question that is on health emergencies in the Q&A. I'm going to pose that question to Dr. Sugandhika. I think it's about the mistrust, about accepting information. It's about information coming from UN, particularly coming from women in health workforce during emergencies. You can talk to it about misinformation, disinformation in emergency operations. Thank you, Dr. Sugandhika, for taking this question. Over to you.
Thank you so much, Niluka. In this day and age, I think misinformation, disinformation is something which is really a part and parcel, almost a part and parcel of emergency operations. I think how we tackle it is through the trust we have in the community workforce. As you see, the community workforce that we work with as the UN, as WHO, is very close to the communities, and that is where the trust factor comes into play. It's not about somebody from outside going and discussing operations or health interventions, but it is we work with the community workforce, with the communities in all public health interventions, where we try to address and respond to the different challenges that we see. So it's basically our role is to work with them and not to look like somebody coming from outside and responding, but working with the communities, with the community workforce, with the volunteer groups, and with the networks, build their trust. And also it's a lot about preparedness as well. It's not that we are starting at when we are responding, but by that time we have already built that trust through years and years of our program work. So that's just a little brief from my experience. Over to you.
Thank you very much. Yes, we live in an era where there's a lot of information, and there can be misinformation and disinformation. And I believe that there's quite a lot of opportunities to screen out these as well. So we are taking another question. I know that there are a number of questions in the Q&A, but for any question that we can't answer, we will try to answer them in due course. But I would like to ask these questions from Dr. Alia, probably, because it's about addressing the culture as well. There's a question addressed how we provide opportunities for women to lead in cultures where women are not usually given leadership, and to how to balance socio-cultural aspects as we go forward decision-making roles. And thank you very much, Dr. Alia, for accepting the question.
No, thank you so much for the question. And there's other questions in the Q&A that are related. And it really makes me think, I'm coming from the world which is really trying to tackle these structural issues, right? In terms of addressing the root causes of the inequalities that are leading to women being less represented in leadership positions, overrepresented in low-paying or unpaid work, for example. These are structural issues. And I will come back to the point that I made in my intervention about the importance of civil society organizations, because just to highlight, they are there before a crisis hits, they are there when the crisis hits, and they will be there long after the crisis has passed. And so for you to be able to have sort of continuity of effort so that it's not a short-term measure, we need to engage with these organizations. It is difficult. In the health sector, I have seen it in WHO. It is not part of the business model. We've had conversations with ministries of health where they are trying to find ways in which to engage with others working in other sectors, including, for example, gender equality or women's ministries within the government, to tackle the complexity of these issues. How do we make sure that we're all pushing in the right direction? And the bottom line is engagement. And trying to do that as meaningfully as possible. If you cannot have this as a financial kind of arrangement, but at least engage and get the insights so that you are making informed decision making. And that's how you can make sure that whatever you're doing is doing no harm to those ongoing efforts to change this, to change systems in such a way that they are more equitable and are advancing the very issues that we're talking about today. And that includes in terms of the gender mainstreaming. It is not an add-on. It needs to build on the amazing decades worth of work that has gone into this across different countries and different sectors, and learning from what others have done and where it is working, and how do we share that knowledge across countries. Thank you so much, and back to you.
Thank you very much, Dr. Alia. I think we will take just one more question, and I would like to ask that question. No, we can. Okay, we can try another question as well. Yeah. So the question I would like to ask from Dr. Stella, the question is more on gender mainstreaming. How can gender mainstreaming be effectively implemented at local government units? So it says, but at least at the local government areas, considering that they are often not prioritized at the community level. Over to you, Dr. Stella, and thank you for accepting the question.
Thank you. I think it's a very important question, because as earlier alluded to, many times you would see that there are policies or things that should be in place and that should be implemented, but they are not. I think that at the local levels and even in the country levels, there are a number of legislation and policies that are in place that should be monitored, their implementation. If we can monitor the implementation and push down and have them locally adapted, bring in the communities, bring in the women to be part of the discussion in shaping these policies and in driving these policies, then it would be more effective. I do think that we at WHO here, we have, and in the Health Emergencies program, developed a gender mainstreaming strategy that we are monitoring very closely and working with all our critical partners to ensure that we are all driving in the same direction. We look at issues in terms of integration into our data, into our capacity building, into our operations in health emergencies. We really try to force that discussion around having sex disaggregated data, gender in terms of age disaggregated data. We look at disability disaggregated data. It's not. It sounds very easy, but many of the tools out there do not contain this information, and we have seen how health emergencies are influenced through the discussions that we have when these gender considerations are not taken into account. We have also looked into the leadership issues. What are the proportions? Yes, women, if you look at it at entry level, they have even higher proportions than the men. But when it comes to true leadership, how many women are actually leading, driving, and shaping the policies and the processes? Very few. So our strategy looks into issues like those. We look into the partnerships and the capacity building. What tools are out there? How are women enabled to improve and to access these different resources that are available and that they currently do not have access to that? So all of these things should translate. And many countries do have policies and legislations around this. They're just not implemented or monitored. So I think that in a country, it would be important that we pull out and map what exists, identify the gaps in there, bring the people who are most concerned to the table to be part of the discussions and the shaping of whatever programs are put in place. I think that we do have right now this pushback that Alia and other speakers talked about on gender. And even here at WHO, we have experienced that during our World Health Assembly, where there was a pushback on the gender responsive language in a resolution of the Assembly. It had to pass, and it passed by vote, showing that member states still, many of them still really want to drive that discussion into gender responsiveness as opposed to just being gender sensitive and waiting back and not taking action, proactive action in addressing the issues. So that passed, and if it did not pass, the impact would have been great because it would set a precedent that could be used to roll back other gender advances that have been made. So I think that this tenacity that we as champions, as women, as supporters, as men who support these approaches are important to hold on to, are important to fight for, are important in making a difference at the local levels.
Thank you very much. And then there's a follow-up question to the gender disaggregated data as well. The question is, how can this health data be effectively shared with decision makers, policy makers?
Okay, I can take some of that, but I think earlier you have a broader view across, all of that. But in health emergencies, what we are beginning to do is actually putting this into the questions that and the data that we collect from our member states that then helps to shape the programs and helps with the recommendations that go back to the member states. So right now we're collecting data through what we call a joint external evaluations that have occurred in over 130 countries to date. We are collecting data on how gender is considered in building capacities in country. And this is really driving a discussion, forcing a discussion within countries on, how these issues touch on health emergencies and the capacities we build by forcing the disaggregated data that speaks and gives the evidence on which we base these discussions and the recommendations. So that is really helping us move forward in that. But in a broader sense, let me say earlier, and maybe other speakers might want to speak to these issues.
Yes, I would like to pose this question to all panelists. So Dr. Alia, Dr. Sugambika, Dr. Mary, Dr. Zarina, as the last question of the session before we conclude. Please go ahead.
Okay, maybe just in the interest of time, and I think Stella has covered it really well, just to say it's important to have disaggregation of data so that you cannot assume a standard and that you would make differences invisible. But to go from data to policy making is a whole chain. And I think that's where our data and analytics team are really working, because you have to go from the data to have the proper analysis and then how that translates into policy recommendations. And I think that's a collective effort, and that you have to make sure that actually data is being used for that. So I think it's something that we all have to work on. I've seen cases where the data is there, the evidence is there, the analysis is there, but the preconceived ideas of the decision makers create an obstacle to making the right policy choice. So it's really an ongoing, but having the data and the evidence is a critical first step for you to do your policy advocacy to begin with. I hope that at least I can answer that part of the question. Thank you.
Any other panelists would like to briefly touch upon that question about the disaggregated data, how policy? Otherwise, we are almost there. We have just 1 minute left, so we are a bit rushing. So I take this moment to thank you, our exceptional panelists. I want to thank Dr. Stella and Dr. Sugandhika Pereira, Dr. Mary Stephen, and Dr. Serena Leung and Dr. Alia Aliasa for joining us today. We have a long way to go. I hope we will continue talking about taking actions towards gender equality, women's empowerment in emergencies and in public health. And all the participants who pose questions and listen in. But before to close the webinar, I hand over to Supriya for back to EPI-WIN. Thank you, Supriya.
Thank you so much, Niluka. And from the EPI-WIN side, we'd like to thank all the panelists and speakers, Dr. Stella, Dr. Alia, Dr. Suki, Dr. Zarina, Dr. Mary, and last but most definitely not least, Dr. Niluka, who's been, the sort of strength and power behind this whole webinar. So huge thank you to all of you. I'd also like to thank everyone who's worked in the background. You see some of them from this room, but not everyone. We have Michael here, who's behind most of the logistical stuff in EPI-WIN webinars. We also have Armorel, probably online, though not in this room. We have Antoine, who's been supporting us, Romina, who's been managing the Q&As for you, and of course, all the participants, because EPI-WIN is not EPI-WIN without the participants. Thank you very much. And on that note, we would like to know what you feel is important from this webinar, because this is for you, and to take away from today and apply it to your circumstances and conditions, and help strengthen women in health emergencies. So very quickly, back to slido.com, #2063361. What, in one or two words, are the most important takeaways for you from today's EPI-WIN webinar? So we see leadership so far as the most important takeaway. I suppose the importance of leadership, empowerment, resilience. So some very powerful words coming up. And we hope you will take that away and apply it. Our survey asks also how you use the information from EPI-WIN webinars. So please do let us know how you use it. And we hope that it's useful for you. So we still have a number of people online. So please, we'd like a few more of you providing inputs to this. Opportunity, some very positive words as well. Resilience, nurturing. Real change, I see, comes up. Justice. Community mobilizers. And another strong word, perseverance. I think that's very important. Okay, so I will stop this now and also just let you know about next week's EPI-WIN, which is next Wednesday at this time, 1 o'clock. And it is on the pandemic influenza preparedness framework. The only public health network for equity and benefit sharing that exists today. And it's been 15 years. This is to celebrate 15 years of strengthening public as pandemic influenza preparedness for a more equitable response. And we hope to see you there. Once again, thank you very much to everyone. And you will get the presentation and the recording on our website. We promise to try and have it up as soon as possible. That's pressure from me and Michael. And we hope to see you soon. And please do continue from this webinar to your work. Continue the good work. Thank you.
Thank you.
Thank you. Bye-bye. Thank you.